Excellent. So I will get the meeting started,
Okay.
and I will do an acknowledgement of country. So I'd like to acknowledge the Gadigal people of the Eora Nation as the traditional custodians of the country we're meeting on today. We recognise their continuing connection to the land and waters and thank them for protecting this coastline, which is the east coast of Sydney, but we've got people from all over Australia and its ecosystems since time immemorial. We pay our respect to elders past and present and extend that respect to all First Nations people present today. So I will start by introducing Professor Paul Roach, and I have known Paul since the 80s when he actually was a resident.
Yep.
So
go back away, don't we?
We do, yeah. So I think the colour of our hair is pretty similar. So
yeah, afraid so.
Yeah. So no, I'm so honoured and pleased that you can be here today and to talk about all things nuclear medicine with our patients. They're very keen to hear everything. So I have got a spiel here about you. I don't know whether you want me to do the spiel or you want to spiel yourself. So
you can start and I'll add to it.
Okay. So as we just said, he did his residency. It was at Royal North Shore when we worked together. And then he undertook special training in nuclear medicine at Royal North Shore, Royal Prince Alfred, and then went to the Harvard Medical School in Boston, USA. After that, he underwent PET imaging at St Thomas's Hospital in London. And since, I think, still 20,000, you're the Director of Nuclear Medicine at Royal North Shore, and also has been appointed as Clinical Director of Nuclear Medicine for the Northern Sydney Local Health District. So Paul's been instrumental in getting the SPECT-CT technology in Australia and the installation of the Northern Sydney's first PET scanner at Royal North Shore in 2010. And he is leading the installation of Australia's first combined clinical and research total body PET-CT scanner at Royal North Shore, which is due this year. And he also, in association with Dr. Liz Bernard, he established the nuclear medicine practice at North Shore Private Hospital, and that's been open since 1998. So I will now hand over to Paul to give a bit more of a blurb about him, and then we can start on the questions.
No problem. Well, firstly, Meredith, thank you for the invite today. It's good. It's always good to see you. And when you ring me and tell me that you'd like me to do something, I of course, I know where my bread is buttered, so I absolutely am happy to do that. So hopefully over the next half hour or so, I can answer some questions and enlighten you all a little bit more about what we're doing with our PET imaging and also a little bit about Lutate if we go into that. I guess the only other things to add to my bio is that Royal North Shore, as you know, is one of a handful of international centres of excellence for neuroendocrine cancer. So the ENETs have a program where they accredit sites around the world. There's about 50, might be a little bit more than that now. And there are only 4 outside of Europe last time I checked, and in Australia we have 2. So Peter MacCallum is one, Royal North Shore is the other. We've been doing Lutate therapy here since about 2013, 2014. So in New South Wales, the first cases of Lutate were treated at St George, and that was part of a trust fund grant by one of the surgeons. And since then, they've continued their program. We have gone for the International Centre of Excellence, which is actually fairly challenging to do. You have to have a lot of infrastructure, a lot of key clinicians and expertise. And so we got over the line with that a few years ago. Peter Mac got through a little bit ahead of us. But I think it's really good that in this country, we've got, centres around the country, and we have a good network. We obviously talk a lot with the other centres that are doing Lutate and also the diagnostic imaging that we'll talk a little bit about. Just some other things I think relevant to me in terms of the NET space. I formerly was the president of the AANMS, which is the Australasian Association of Nuclear Medicine Specialists. As part of that, part of our brief is to try and get Medicare funding for various things, particularly for scans. So I led the process that led to Gallium Dotatate getting Medicare funding a few years ago. And I know that's something of enormous benefit to many people that are on the call. I just want to also say we were probably lucky to get that one over the line with very few restrictions around it. I think the federal government assumed that most people would get 1 or maybe 2 scans. And I mean, a lot of people do only need you know, 1 or 2 scans. I might get 1 a year, but as quite a few of you know, a lot of people need to get a lot more scans than that. So I noticed the current one that looks like it's getting over the line is around prostate cancer, and there are very tight restrictions on that. You'll get 1 at diagnosis and only 1 funded during the follow-up. So I just want to say to the NET patients, we managed to get that one under the radar, and I think luckily for all of you that do need, for those patients that do need to get a lot of scanning, we're just very lucky that Medicare funds it. The other thing I was just going to say too is around Lutate funding in New South Wales. That was a particularly challenging process, dealing with the bureaucracy and certain ministers within New South Wales Health and the New South Wales government, but we did get over that line. And so we in St George are both funded to do Lutate therapy. We have criteria that patients need to meet. They're pretty broad criteria. I wrote them in conjunction with Patrick Butler, who is my equivalent at St George Hospital. So I think, again, we're very well placed, but I really need to acknowledge, as we were finding it challenging to get the funding sorted for that, and particularly, you know, I heard comments back, it's unproven, and, you know, there isn't enough trial data and so on behind it. We brought in our heavy guns, which were John Layden, Nick Pavlakis, Meredith, etc., and Unicorn, as it was back then, were very, and Simone, obviously, Unicorn or now NECA were very helpful at that time in securing that. So I think that's just something I'd say we have good links to the patient advocacy groups as well as the medical oncologists and so on, and we really do need everyone working together to get money and to get things out of government. You know, we're not going to do it in isolation. We need the support of everyone. So I think, again, we're very lucky in this country to have such a strong link, and such a, particularly with NECA, a very active support group. So they're the only other things I thought I'd just add. Meredith?
Yeah, and I've just had a question come through from Karen, who's actually in Queensland. Any chance it is possible to include lungs in Medicare funding?
Yeah, the Medicare descriptor won't change now. I can't see that that's going to change, but yeah, it does talk about GP nets, doesn't it? So yeah, so that one that's going to be a little bit challenging. So it's yeah, it was hard enough to get this over the line. And I'm not aware of any attempts to change it at the moment, but a lot of our referrers are very broad in the boxes their referral boxes they tick, but yeah, creative, yeah. But having said that, we need to be careful.
Exactly, yes, because yeah, Medicare does audit, so yeah, we need to make sure that things actually are correct.
Yeah, and I think just on that, there's a lot more Dotatate scanning going on than they expected, and I think. And again, I know you're recording this, so I better be careful what I say, but I think what they would have seen at first, once that item number came out, there was probably quite a significant jump in the use, but it's probably now plateaued. And I think as long as it stays like that, they're not going to look too hard at it. But, you know, if expenditure just keeps going up and up, that's when they do get very interested. So I did have a couple of comments made to me a few years ago about it, but then I've heard nothing since. So hopefully we're just, and look, you know, I think we do the scans that we need to do. We're not doing them unnecessarily, and as I said earlier, some people need very few of these scans, but some do need to have them quite regularly. So we will continue to fight. You know, if there is any pushback, we will certainly argue strongly that you know, we need to, it's a broad disease process, and not everyone is in the same category. People behave differently. Some people have a relatively benign course, some have a more aggressive course, some can start with one and then turn into the other. So you know, it's an interesting area of medicine, and but you know, not everyone patient doesn't fit the same box.
Exactly, yeah. So I've got a question. One of the patients coming is interested in the difference between Dotatate and FDG PET scans, and when to use them, and what diagnostic information do they show, and also can a cancer be sensitive to both?
Yeah, okay. So all right, so with PET, so these are both PET scans. So PET's positron emission tomography. This has a you know, a big PET scanner. Most of you, I'm sure all of you will have had PET scans over the years. So these are sort of $2 or $3 million pieces of equipment. But what we see on the scan is determined by what we inject. So the most common thing that we inject is FDG, which is fluorodeoxyglucose. So it's F18 is the isotope. So fluorine deoxyglucose. So it's looking at glucose metabolism, and many tumours and most tumours will be positive with that. So this is the bread and butter PET scan that we do. So and there's a lot of different malignancies that we investigate and we manage. So at diagnosis and to assess treatment response, things like lung cancer, colorectal cancer, sarcomas, head and neck tumours. There's a lot of different types that we do. So that is the most common PET scan done in Australia. Dotatate is a different thing. So it's not looking at glucose metabolism, it's looking at somatostatin receptors. So the majority of neuroendocrine tumours, particularly the well-differentiated neuroendocrine tumours, will express somatostatin receptors, and there's different subtypes of that. But that's what we're looking at. So it's made differently, it goes to different parts of the body, and it's targeting a different thing. So and the point of doing this, of course, is that if we look at lutate therapy or PRRT, it's targeting the somatostatin receptor. So before we give anyone lutate, we want to know whether it's going to work. So is the somatostatin receptor being expressed by those tumours? So, and the thing about neuroendocrine tumours is that invariably, for most people, we need to do both. The most important one is the Dotatate scan, and that's the one that's most likely to be positive. But in some patients, particularly with more aggressive disease, the FDG scan can be positive. And sometimes we see people who've got certain parts of the certain tumours or certain clones are positive on one and not the other. And that then becomes an interesting treatment discussion for us, because with Lutate, we can target anything that's Dotatate positive, but if it's Dotatate negative, and particularly if it's FDG positive, it's a more aggressive sort of tumour, and then you have to think of other treatments, other biologics, chemotherapy, and so on. So, so I'm sure. And in terms of the neuroendocrine tumours, who gets them, look, I think probably the majority of you that have gone down this path have probably ended up having both. You probably get at least one FDG scan at some point. But the more well differentiated, and this is based on the pathology. So, when they do the biopsy, there's a thing called a Ki67 or Ki67. That gives you an idea of how aggressive a particular tumour may be. If they're very low grade, and particularly if things aren't changing over time, you probably may never get an FDG scan. But if you have a high grade tumour on pathology, or it looks like, as you have your different scans, that it's progressing relatively quickly, certainly FDG would be in the mix. So it really, again, varies from person to person. So yeah, two totally different types of PET scans, but for a lot of you would be you'd be getting both of them.
Yeah, and the other part of the question was, can a cancer be sensitive to both? So
yeah, so yeah, absolutely. And I mean, we see this all the time. We see the whole combination. You may have someone that has tumour that's only positive on Dotatate and nothing at all on FDG, and that tells us that it's a more well differentiated tumour. And we may watch that. If it's starting to change or evolve or progress, then we might. That's the sort of patient we'd be looking at Lutate. We have other patients that are positive on both. So you literally put the scans up next to each other and they're showing exactly the same thing. As long as the Dotatate scan is positive, Lutate or PRRT is definitely a treatment option. If there's FDG positivity in the mix as well, so at the same sites, then that starts to tell you it's a bit more aggressive, so we may want to get involved in treating earlier. And then you have other tumours which show nothing on Dotatate and they're FDG positive. So and that's again, these are people that we would not be treating with Lutate, but you'd be looking at other treatments. So the answer to that is yeah, we have some people where the two scans match each other perfectly. Some are Dotatate positive only, some are FDG positive only, and obviously that leads to different treatment options.
Yeah, so would you, like where they're both positive, would you look at the combination, sort of PRRT and chemo?
Yeah. No, if they're both positive, you may do well just with PRRT.
Right.
So again, the term that you'll see on some reports is called discordant. And so what we're looking at there is, are there sites of disease that are FDG positive, but not Dotatate positive? So the point being, if we treat with Lutate, are there areas that are going to miss the treatment effect. For Lutate to work, it has to be binding to the somatostatin receptor. So it will only work on areas that are Dotatate positive. So what we're particularly looking to on an FDG, and in many respects, we don't care whether it's positive or it's negative, but what we do care is it showing up at sites that are not Dotatate avid, because they're the ones that tell us you're going to have to look at a different treatment. So with FDG, if you see the term discordant or concordant, but particularly discordant, that's what we're looking for. Are there areas that are FDG positive that are Dotatate negative?
Okay, and I have got a question that's come through. Can a tumour change from FDG to Dotatate positive?
Yep. They can, and again, they work both ways. I think it's more likely to sort of go the other way, where you might be Dotatate positive and then it starts to transform into something more aggressive. Usually it's less common for it to go the other way, where I think if it's sort of FDG positive up front, typically that's behaving, that's a sort of a more aggressive course. But I mean, I can think of one of our patients that we've done so many scans on over the years. She's just changed. I mean, it's just bizarre to watch what's going on. You know, you look at the scans and think, oh my God, and then we give a little bit of Lutate and it all just goes away, and then it stays like that for a couple of years, and then it comes back in another part of the body. It's a really, it's predicting the future can be very hard with some of these.
Yeah. Now, so we're going to move on to avidity. Well, does avid generally mean growth, activity, both, or something else? And also explain the term Dotatate avid disease.
Yeah, okay. So, if you're an avid reader, you like to soak things up and, read lots of books. So the term avidity, and I think there is actually a biochemical definition, which is the binding of an anti-antigen and an antibody. So look, the way we use it, it's a term that we're just using to see how much uptake there is on a scan. And I'll use another colloquialism that we tend to use quite a bit, whether the scan is hot. So, you can, if there's say a lymph node or a lesion or something, is there much Dotatate uptake in that? So is it faint uptake? Is it moderate uptake? Is it marked? So the term that we use around that is avid or avidity. So we'll say high avidity, low avidity. So it's a way of describing how hot or how much uptake is going into that. The numerical terms that we use, and I'm sure this is another question that's on the list, is about SUV. SUV is a standardized uptake value. It's a mathematical thing that's really looking at how much of the injected dose is gone to a particular place. There's a formula behind it that involves weight and injected dose and so on, but it's the same thing. It's the same principle. It's a number. So we might quote an SUV of 2 or SUV max of 2, which means it's very low grade uptake, as opposed to an SUV max of 50 or 100, which has got very high grade uptake. So, so in that term, we'd either say there's very high avidity in this lesion or very low avidity. So there's just, the term avid is just a descriptive word about how much uptake is in a lesion. The SUV is a numerical term, giving particularly our referrers a number. Okay, all right, so that's really avid or it's not so avid. Yeah.
Okay, so we've got a few questions here about SUV, but there's one: what do SUV mean on Gallium PET scans and things? So I think you've just said as far as uptake and yep.
And I think just the other point too is you might look at that number and be worried and think, oh, that's not good. That's a really high number, or they've used the term high avidity. On Dotatate, that can actually be quite good, because again, if you're starting to think about Lutate treatment, you want that somatostatin receptor expressed. So if you had lesions that we described as high avidity and an SU max of 50, 80, 100, that's good. Because if we treat, then it suggests that you'll have good binding. If it's very low, we'd be a little cautious, because you think if we give Lutate therapy, it may not bind very high, and you have to balance sort of where this goes in the body. You ideally want it to go to tumors and not to other areas. We'll see uptake in the kidneys and liver and so on. So with Dotatate, we actually would prefer a high number. With FDG, it's more the opposite. With FDG, there is a relationship between the number or the avidity and how that tumor is behaving. So if you have a high number or a highly avid tumor, that suggests to us we're dealing with a more aggressive disease. So as I say, if you particularly with the Dotatate scans, don't be worried if you see terms like high avidity and big numbers. It doesn't necessarily mean anything's bad.
Yeah, because there was a question, does a high score mean PRRT might work better or the patient has more receptors? So
yeah, so it probably does mean that there are more receptors, and in terms of will it work better, there's not like a linear relationship. I can't say if someone's got 20 and someone else has got 80 that you're 4 times more likely to work with the 80. There is a sort of cutoff around about 15 or 20. I think below that we question whether PRRT is really a good option and whether it's going to be effective. Beyond over that, and they used to refer to a Krenning score, and I think you had a question about that. So that's similarly what that's about, and this is based on Eric Krenning was a nuclear physician from Rotterdam, I think, and this is based on the old indium scans. I don't know, a few of you may have had those, but they're compared to what we're doing now. It's just, you know, the Dotatate scanning now is just so impressive. But what they did there was, rather than have all these numbers, they compared it to other parts of the body, basically the liver and spleen. So it's like a 4-point scale. So is it less hot than the liver, and then is it between the liver and the spleen, or is it more avid or hotter than the spleen? So it's an easy way of looking at a scan and conveying a way of yes, this is a particularly avid, or it's not a particularly avid tumor. We don't use that term anymore, although in America I noticed they've sort of modified it to PET, but you know, I think between our descriptions and our numbers, we give our oncologists the information that they need, but I have seen that used in some American things.
Perfect. I've got also here, I'm not sure if this is right, but I've heard about a new form of lutate. Currently lutate B is given, but apparently there is a lutate A now. Please explain.
Not sure I know the context around that. Lutate A or B, there are different trials going on with different modifications of compounds and agonists and antagonists and so on. So there's a bit of trial work there, but look, I don't think, you know, I think the lutate that we use is pretty much the same that's used around the country. The lutetium can vary a little bit. Sometimes we get it from ANSTO, other times we get it from Europe, and there are slight variations in that, but the efficacy, the effectiveness is very similar. So yeah, you're ahead of me with lutate A and B. I need to,
I'm
I'll
just
need to
wondering
see what
whether
that's about.
I'm wondering whether it might be the alpha emissions
Oh,
that they
alpha,
are doing
yeah,
in
okay.
Germany as opposed to beta. I think that might be the,
Okay, so yeah, there is a little bit of work in that. There are different particles, and again, I don't want to sort of go into huge detail. Plus, I'm not a physicist, so my knowledge is not as high as some. But the gamma cameras pick up gamma rays, and so a lot of what we do in nuclear medicine is gamma imaging. What we're doing with the treatment is beta treatment, so this is beta radiation. So that has a path, sort of a couple of centimeters, so it will cause destruction within a few centimeters. Alphas are the other ones, and they're more potent, but they have much shorter path length, so only a couple of millimeters. And so there is some work going on with trials around alphas, and I think there are parts of Germany that offer this as well. But again, I think like anything, we would start with our more bread and butter lutate. It works in the vast majority of patients, but in some that are progressing, you might want to start to think about moving on to something like an alpha. We actually do that a bit in prostate imaging as well, because we're treating PSMA. We're treating prostate cancer patients with PSMA, and again, it's the same principle. It's generally with lutetium, but in some patients it just doesn't respond, and you know, there's a bit of, in Australia, a few places have been looking at alpha, but I don't think on the net landscape in Australia there's much alpha therapy going on, but it'd be more trial work.
Yeah. And this one, is there an ideal SUV score after treatment as a PRRT? And I've also got, is there a normal score?
Okay, so a normal score, it depends on the organ. If you have if I had a scan, my liver would light up kidneys, spleen would light up, salivary glands would light up, pituitary glands. So there are normal parts of the body that express somatostatin receptors. And some of those numbers can be quite high. So, you know, the liver might be 20 or 30, the pituitary might be a bit higher. So, but if you had a lesion or a tumor or a node somewhere or other, you'd expect it to have little or no uptake. So I think the answer to is there a normal score, it does depend on the whereabouts in the body. There are physiological places where somatostatin is expressed. Is there an ideal score post-treatment? Look, I think the thing that you're looking at more is what's the pattern? And that's why we do the surveillance scanning. So you'll have sites of disease, whether they're in lymph nodes or the liver or bone or whatever. Then we do the treatment, and the follow-up scan is, we're not so much looking at the numbers, we're looking at the pattern of disease. And obviously there are three things: has it got better, has it got worse, or is it relatively stable? So we don't worry too much about the numbers, we look more at the pattern. So when I do a surveillance scan, it's very simply, you know, the opening line of the conclusion is stable pattern of disease, or there has been improvement, or there has been progression. So more concerned about the pattern than the number.
Mm-hmm. And I've also got, how long does Lutate, oops, hang on, somebody's just put another question and I missed it. How long does Lutate keep working in the body after treatment?
Yeah, and it goes on for a while. So, you know, it's got a half-life of, lutetium has a half-life of 6.7 days. So from the time we inject it, it's still sitting there and it's continuing to do its job. So, so it will, what happens is when you inject the lutate, a lot of it will go to where in the body it needs to. So you have it in the sites of tumor, you'll have it in the other sites. And I mean, as you know, those of you that have had this, we have infusions going. We're trying to just reduce the kidney dose in particular. But when you leave the department, it's still sitting, doing its work in the various sites of tumor, and it will continue to do that for days and you know, even out to weeks. So that's why we sort of separate these treatment cycles. They're typically about 8 weeks apart, because the first treatment will be working over a period of a week or two, and then, you know, then we'll leave that for a while, then we'll do the second one. So it does continue to work for really weeks after the treatment.
Mm-hmm. And I have got here, what scan detects the overall mass and size of the tumour, Gallium or FDG or other?
Probably more other, so it'd be CT. So, I mean, as you know, when you have a PET scan, you also have a CT. Usually it's, well, we refer to it as a low dose. So it's a low radiation dose, non-contrast CT. It's a bit different to what you get if you went to your local radiology practice, where they give a higher dose, they get higher resolution, they're giving contrast and so on. But anatomically, you get much better information on the CT than on the PET scan. But we do the combination. So so we would look at, say you've got a lump somewhere or other and you're having a progress scan, we would sort of say it's changed in size and it's changed in avidity. So we would give a rough estimate of size. You know, it's gone from 3 mils up to 10 mils, and the SUV max has gone from 10 up to 50. You know, that's clearly showing progression. So they do want to know, our oncologists, our referrers do want to know that. So not only what's happening on the PET part of the scan, but also what's happening on the CT part of it as well. So CT is the best thing for showing size of lesions. Yeah.
Mm-hmm. And what percentage of lung primaries do not have receptors for gallium scans?
Oh, now you're getting tough questions coming.
Look, bringing out the big guns, yeah.
That's right. Okay. Look, the majority of them do. It's a little bit less than the gastroenteropancreatic ones, which are the most common. Lung nets are an interesting thing. So they're referred to as either typical or atypical carcinoids, and again, they just run the full spectrum. So the answer to your question is the majority, and I think you're talking, depending on the series, 60, 70, 80%, somewhere in that realm, which is probably a little bit less than the gastroenteropancreatic nets. But again, they can all look very different. So you see some patients that are dotatate avid, like exquisitely dotatate avid and nothing on FDG, or you see the opposite. You see them that are very FDG positive, little or no dotatate uptake, and again you find some in the middle where you get both. And again, the thing about this is if we weren't seeing, it tells you a bit about how aggressive the behaviour, and certainly if something that was FDG positive, not really dotatate positive, if that was spreading or in different places, you certainly wouldn't be looking at PRRT or Lutate. You'd be looking at chemotherapy or another similar systemic therapy, or surgery. Obviously, if you can cut them out, that's the preference. Yeah.
Now I've got, does the pathologist, I'm thinking maybe radiologist, reading the CT, see the tumour and organs in 3D? Is there a special software?
Yes, there is. So yeah, it's not the pathologist. So remember, the pathologists, these are the guys and girls that look down the microscopes at the biopsy specimens. So I'm a nuclear medicine physician, so I'm actually not a radiologist, and I should just explain that. So in Australia, nuclear medicine specialists are either trained as radiologists or as physicians. The vast majority of us are trained as physicians, but we obviously see a lot of scans. So we've sort of got a skill set that's a little bit between the both. And radiologists typically don't have much training in cancer treatment, but they're obviously very good at cancer reading. So anyhow, just to explain that background. So in terms of, what they do, so they look at things in 3D, as do I. I mean, if I'm looking at a Dotatate scan, we look at it sort of front to back. We go from head to toe, and we could go from side to side. And the most common way we read these scans is literally from head to toe, going through slices like that. It's called transaxial slices. And if you look at a CT picture, that's usually what you're getting. But I think it's very helpful. The other thing that you do is sort of from front through to back, so you can sort of see the head and the chest and so on. That gives you a very good overview of what's happening, and particularly in that key question that I mentioned earlier is, what's the pattern here? Is it stable? Is it getting better? Is it getting worse? So we look at and radiologists, we look at them in all three planes, and we do have pretty good software for doing that. And we can change window intensities. So sometimes you want to look at the lung, sometimes you want to look at the soft tissue, sometimes you want to look at the liver. So we've got buttons that we can press that change the look. So all very fancy. Yeah.
It is. It's amazing sort of when you look at it, and so basically you've got a body in front of you sort of, with all the 3D. So,
and Meredith, we have the advantage of color. So, if a radiologist looking at a PET, looking at a CT or an MR, they're usually looking in black and white and gray, whereas I'm sure a lot of you have seen our scans. When we superimpose them, it's very hard to put black and white onto black and white. So we actually have color. So our images sometimes look really good.
Fabulous. I just thought I'd ask a question as far as PRRT. What sort of is a maximum, or is there a maximum retreating? Because I know there's people who have had years.
Yeah. And so is there a maximum? What's the most that I think the most I've seen here is probably 10 or 11 treatments. I can assure you I've been at Richard Baum's unit in Germany, and he's treated more than that, although he's not there anymore. But I think, look, the usual way we go is we'll do 4 treatments. We may reassess after cycle 2, but we certainly will reassess after cycle 4, and then let's see what happens. And for a lot of people, that's good. It stabilizes things. It might work for a couple of years, and then it starts to rear its head again, and then we can look at more treatments. So we definitely have had patients here that have got up to 10 or 11. What you're starting to balance then is risk, I guess. It's the disease progressing. Are there any other treatments? Obviously, the more radiation, you start to worry then about secondary cancers. But some of those take a hell of a long time to develop. So it's like you kind of think, all right, well, we've got a tumor that's now clearly progressing. This is the best treatment. And so we will look at that. We'll look at what kidney dose there's been and so on. So we're just obviously a little bit more worried about the safety, but ultimately you've got to make a call. And there's a theoretical risk about radiation leading to secondary malignancies, but often that's 10, 20 years later. And if you don't treat, you won't be here 10 or 20 years later. So we can retreat, but our usual starting cycle is 4.
Yep, great. And what's in the pipeline or in the future for Nuke Med and NETs? Are there any advances that you can enlighten us with?
Okay, another good question. So I think So on the technology front, you mentioned earlier the total body PET scanner. So we're looking forward to that. So that will shorten our imaging time here at Royal North Shore. So hopefully, probably it's going to be realistically this time next year before we put that in. But that's one thing. The other key thing, I guess, is, as I alluded to earlier, there are some trials going on with different isotopes, and rather than Dotatate moving into things like antagonists and so on, they've probably got higher binding. So I think you'll find as those trials are underway, we'll probably ultimately that will transition a little bit into maybe a different type, rather than Dotatate, into different types of things. And also you mentioned the alpha therapies as well.
Would that be the copper that you're talking about?
Yeah, well, that's right. So copper is one. We're part of a copper trial. So copper 64 is a diagnostic and copper 67 is the therapeutic. So there are a lot of those sort of things going on. The copper images, I must say, look quite nice. And but what we don't know yet is it better than what we're doing now with gallium, and ultimately treatment-wise, is it better than the current Dotatate? So that's all part. And look, Royal North Shore is part of one of the trials looking. We are comparing in patients copper 64 with gallium 68. So we're one of the sites around the country recruiting to that one at the moment. I think there's about 4 sites. So yeah, these are all things. They'll take a few years to work out. But if we're having this chat in 5 years' time, we might be talking about copper scanning rather than gallium scanning. So we'll see.
Yeah.
Time will tell. Let's get the evidence in and see what it all shows.
That's right. And I think it all has to do, a lot of it, with the manufacturing as well, and the availability.
Yeah. And look, we're also lucky in this country. It's and I think it is an important point for everyone to realise, we have a pretty dynamic group of people who are interested in METs at the key centres. We've also got good links to industry. Industry are certainly happy to do trials in this country, which and the copper one is a very good example of that. So we're in a good space. If you look around the world at the sort of countries you'd like to be in if you had this disease, this is probably one that is a good place to be. And plus, as I say, in recent years, we've also, a lot of the financial issues have become much less with Dotatate funding, and with I think in most centres, or most states offering as required Lutate therapy.
Wonderful. I haven't got any more questions. I don't know, does anybody have any more that they want to ask? If you want to quickly scratch them on there. I did have one person who is a relative that you've been looking after. Well, she's the relative of the patient that you've been looking after, and just wanted to say how wonderful you were, and thank you so much.
Good. All right. Thank you.
Yep. And I have got, where do we get our Lutate from? Is it manufactured here?
So yeah, it's the answer to that question is yes and no. We buy we either source the lutetium from Ansto, so that is locally made. It's a little bit more expensive, or we get it from the Netherlands. And here at North Shore, it's a bit of a mix. Again, it's largely related to availability, and obviously during COVID there have been certain supply issues. So at times we're lucky to get anything. So so we actually do get it from either place. So Australia, so it is good. Australia is now producing this, and I think as the last few years have shown us, the term is sovereign supply. I think to be able to produce this stuff locally rather than have to rely on air travel and other things is really helpful. So it's a combination. Yeah.
Perfect. So I have no more questions coming through. There's lots of thank yous, and very interesting. And I know you have got another meeting that you need to scoot off to. So
that's all right.
Yeah, but we are so grateful for your time and for explaining so many things to people that have been questions that have been burning away. So
no trouble. All right. Well, I hope that that's been of benefit, and you've learnt some things. And again, just to reiterate something I said earlier, I think we're very lucky in this country to have a group like yours, Meredith. So to you and Simone and everyone, you're doing a fantastic job. And I know your patients appreciate, but I got to tell you, we as professionals really appreciate what you do.
No, well, we enjoy working with you and always have done. So and you offer so much to so many, and I think for a less common cancer, it's so wonderful to have such a great group working all together. So
and that's how we succeed. We've all got to work together on this, so it's really important. Yeah,
absolutely. Yeah, well, have a lovely weekend, and many thanks again.
All right, thanks a lot. Thanks everyone. Goodbye.
Thanks everybody. Bye.